Today we'll be talking about an interesting muscle, and there has been a lot of research and done on it and stuff published on it. I still see people joining in, so we'll start in a couple of minutes. Talking a little bit about this muscle, there has been stuff published by anatomists, morphologists, people who do EMG studies from low back pain point of view. Wide variety of research and wide variety of ideas given by various researchers, and that's why this topic becomes more and more important. When we teach our lumbopelvic module, we talk about this a lot because the amount of research published on this is ridiculous. So and that's why this topic is very relevant and very important, because the amount of research that has been published in this area. Yeah. Yeah, I think this is a very research heavy topic, because then only it will make sense and why we need to know about multifidus, because it's a very research heavy topic, and we're talking about one muscle, and we're talking about looking at that muscle from like various viewpoints and various research ideas we'll be discussing, and how we can use that information clinically and apply on patients so that we can actually use it to our advantage and help our patients. Okay. I think this is a good time to start. I think we're almost past 8:30 Central Time. I think 7 a.m. India time, 7:05. Dr. Steve, you're not audible. Do you have something to say before we get going?
No, just I'm excited to listen in on this lecture that you put together, Dr. Singh.
Okay. So 7 p.m. Yes. Okay. So let's talk a little bit about key points why multifidus is interesting to us as a therapist. I'm going to just bring a skeleton so it makes more sense of it. So if you guys can see, and this lecture is very focused on lumbar multifidus. So we're going to just be talking about lumbar multifidus because low back pain is a huge research area, and multifidus has a strong association with low back pain. So if you look at the spine, okay, multifidus is the medial most muscle. It sits very close to the spinous process. Okay, it has invaginations going from sacrum to L5, L5 to L4, L4 to L3, L3 to L2, L2 to L1. Okay. As far as action of the muscle is concerned, it actually helps you to side bend. Okay, it's a side bend. The research on whether it's a rotator is conflicting, whether it's a ipsilateral rotator, whether it's a contralateral rotator. If you look at different literature, some literature says that it helps you rotate to the opposite side, and some literature says it helps you rotate to the same side. A lot of EMG studies have been done where they found that multifidus kicks on even when you're not moving. And that research is very interesting because, yes, it's a rotator and a side flexor, but a lot of research out there which says that you don't even have to move to kick on or kick in multifidus. Okay. Okay. So this is a muscle of choice, and people have researched it. I mean, some people divide the muscle into three parts: superficial fibers, intermediate fibers, and deep fibers. Though it's a little bitty muscle, but it has been divided into three types. Most of the research says that we should divide this muscle into only two types: superficial fibers and deep fibers. The difference between deep fibers and superficial fibers are that deep fibers are present between two segments. So if I have to talk about deep fibers, the deep fibers are present between L5 and S1, L4 and L5, L3 and L4, and so forth. As far as superficial fibers are concerned, they go from more than two segments. Okay. So fibers from S1 can go to L3. So they travel from more than two segments. Okay. Why all this is important? Because the role of deep fibers is very, very different from role of the superficial fibers. Okay. When we look at the EMG literature, they found that the superficial fibers control rotation from side to side. Some literature says that controls rotation to ipsilateral. Some literature says it controls rotation to the contralateral. Deep fibers have a very, very strong association with shearing movement of the vertebra. Okay. When you're moving, when you're lifting your arm, when you're trying to do a certain activity, the first thing that happens is deep fibers of multifidus helps stabilize the vertebra. Okay. Let me show you a good picture so that this all makes sense. So this is a zigzag muscle coming from the mammillary processes and inserting on the spinous process. Okay, lateral side of the spinous process. Okay. If you have any questions, if you want me to explain anything, I will. But this is a very research-heavy lecture because we're trying to understand how this muscle is important to us. Okay. So please pay attention. Okay. So a lot of morphologists have studied this muscle in greater detail, and they've divided the muscle into a superficial fibers and deep fibers. Deep fibers are very type 1 in nature, which means that they are like slow oxidative. They are like kind of postural muscles. As far as superficial fibers are concerned, they are actually very, very similar to erector spinae, which is your primary spine extensor. Okay. Superficial fibers are, the role is also primary role is also extension. When we talk about deep fibers, the primary role is a little bit of rotation, but the primary key role is preventing this shearing between the vertebrae. Okay. And that's why deep fibers are very, very important. Deep fibers of multifidus are important, and they have been studied vastly more than superficial fibers. Okay. Looking at the physiological cross-sectional area of deep fibers of multifidus, you can see the cross-sectional area is of our type 1 fibers is much, much higher when you compare multifidus with erector spinae. And we're studying here deep fibers of multifidus. So you can see how, so this is a little stout muscle, but extremely dense. Okay. And extremely dense for type 1 fibers. Okay. Yeah. Looking at the fiber type 1 fibers are more compared to type 2. Okay. More research. If you look at the motor unit size, we're talking at the microscopic level now. So looking at the motor unit size. Look at the type 1 motor unit size here. I mean, for a small muscle, it can range up to greater than 12,000 muscle fibers per motor unit for a little bitty muscle. Okay. Yeah. Recruitment pattern. I think this is important for us to understand. So whenever we are studying multifidus and we're talking about multifidus, the difference between the recruitment pattern is important, because when patients come to us and we are trying to assess the recruitment pattern and ask the patient to do any activity like raising the arm or raising the leg, the deep fibers are recruited first. Okay. And we'll talk about the lift test, and we'll talk about how this is clinically relevant to us. Okay. So point is that deep fibers are recruited first. So for example, if I'm just lifting my arm and I'm feeling for my multifidus, the deep fibers will kick on first over superficial fibers. Patients who have low back pain, the activation is delayed. There have been interesting studies. I think when we were in Delhi and Bombay, we were talking about how patients can present with low back pain without the absence of tissue damage. And we were talking about central sensitization. The research says that if the patient has gone through that process of central sensitization and pain processing is affected, it tends to affect the deep fibers as well. So the idea is that if your patient has central sensitization, definite and low back pain, definitely assess the deep fibers of multifidus. Okay. Okay. So this is the evidence we have for deep fibers of multifidus as a chief stabilizer. Deep fibers of multifidus are primary stabilizers of lumbar spine. Superficial fibers are extensors and rotators. Okay. Some research says that deep fibers also play a key role in rotation, but they're primary stabilizers of lumbar spine. Okay. Greater percentage of slow twitch fibers or type 1 fibers, which means that even if you're at rest, deep fibers of multifidus are still activating. Okay. So they are tonically active with arm movement, with trunk motion. Your deep fibers of multifidus are always working. Okay. They tend to co-activate with transverse abdominis. And there is a lot of embryological research done on it that if you kick on transverse abdominis, you kick on deep fibers of multifidus. Okay. And if you have low back pain, they tends to shut down. And we'll talk about various theories proving that fact, that how deep fibers of multifidus just shut down with low back pain. Okay. Okay. Study done by Hides. Hides have done like tons of research, and this research is not new. He first published his first article in 1990. I think he published another article in 1994, 1998, 2008. So just to make sense of it, just to simplify what he said, if they have found that multifidus undergoes atrophy if you have back pain. Not just atrophy at that same segment, at that same site. So if I have right L5S1 facet arthropathy, I'm going to have atrophy of right L5S1 deep fibers of multifidus. Okay. So the problems are occurring segmentally at the same on the same side. Okay, that's what research says. Okay. Usually what happens is, I think Dr. Steve was talking about it when we were teaching in India. Usually what happens is the muscle undergoes atrophy and you have fatty deposits or fibrous connective tissue infiltration. And we'll talk about this. Usually it has been seen that L4, L5 segment is most commonly involved, research by Kader. So every time you're treating a patient with low back pain, make sure you assess L4, L5, because you're going to find multifidus atrophy at that segment. Also L5S1, but L4, L5 is the most common segment where you'll find muscle atrophy. And we'll talk about treatment ideas and what research says, how we should address it. Okay. Okay. Any questions till now? I know this is a lot of theoretical stuff, but this is important stuff. As a therapist, okay. So what happens is, if you have, for example, if I have to show you here, if you have, this is the right L4, L5 facet. Okay. If you have a facet dysfunction or a facet arthropathy, the same segment of the muscle of L4, L5 on the same side will just inhibit. we're going to talk about the assessment of multifidus individually. Yes, that's why I want to just build this up so that you understand what research says and what the anatomy, morphology, and physiology is. And then I'm going to go to the assessment, how we assess the multifidus individually. Okay. We spoke about the recruitment pattern, how when we do any arm motion, trunk motion, deep fibers of multifidus kick on first, followed by the superficial fibers. Okay. So if I have L4, L5 facet arthropathy, multifidus, deep fibers of multifidus will inhibit on the same side at the same level. Okay. And I will explain why. If you look at this picture, and there have been various theories. If you look at this picture, consider this as L4, this as L5, right? If you have a facet arthropathy here, it will just shut down the multifidus, deep fibers of multifidus at the same segment on the same side. They have done studies. They've done studies where they found that a patient has facet involvement on one side, and they had multifidus atrophy on the same side at the same segment, and perfectly fine multifidus on the opposite side. What is the relation between arm movement and multifidus? So studies were done where they found that whenever you lift your arm or start an arm movement, multifidus on the opposite side. So if I'm lifting my left arm, we're going to talk about SI dysfunction and multifidus as well. Let's talk about arm movement and multifidus first. So whenever you lift your arm, even before you start initiating the motion, EMG studies says that multifidus kicks on to stabilize your spine. Okay. And they have, and deep fibers are recruited first, followed by the superficial fibers. Okay. And all the research we are discussing will give us enough foundation to understand and how we should assess multifidus and treat multifidus. Okay. Okay. Going back. Okay. So there have been various theories given why this is happening, why multifidus at the same segment is shutting down on the same side. One of the theory was given was something called as dorsal ramus syndrome. Dorsal ramus is the nerve that supplies the facet joint at that segment and also supplies the muscle at the same segment. And I'm talking about deep fibers of multifidus. Okay. So I'm talking about L4, L5, dorsal medial part of dorsal ramus of L4 supplies the facet of L4, also supplies the multifidus of between L4 and L5. Okay. So the theory says that because you have facet arthropathy, it causes irritation of the dorsal ramus nerve, thus affecting the multifidus at that segment. Okay. If this theory was not convincing, there was another theory given by, I think this is the theory comes from Kajer. And this theory calls for something called as reflex inhibition. So what is happening is degeneration is happening at a facet joint somewhere here. Okay. And this degeneration creates this stretch reflex in the capsule, thus activating the inhibitory interneuron. This is a second order neuron. This is a first order neuron. And then this inhibits the motor neuron, which is a third order neuron. Okay. And then muscle becomes atrophy. I mean, the amount of evidence available for multifidus is stupid. The amount of evidence available. It's just so much evidence. They've done so much research. What they've also done is they have, in certain research, certain studies, what they've done is they've created the pain environment deliberately to see the response in multifidus. So what they did was they injected saline in the facet joints to stretch this capsule of the facet joint And what it did was it absolutely shut down the multifidus at the same segment, at the same level. Okay. And very little effect on superficial fibers of multifidus, but deep fibers of multifidus absolutely shut down after they injected that saline or injected anything in the joint space. Okay. And that's why this research is very important, because that's what happens. Patients come in, they have chronic pain, they have facet issue, and just multifidus absolutely shut down. Okay. Okay. Kajair also gave this degeneration grade where this is done on ultrasound, muscle ultrasound, where they found that less than 10% of muscle atrophy is considered normal. But if it's 10 to 50% is considered grade 1. And if it's greater than 50%, it's grade 2. Lifting the left arm would activate. Research says lifting the left arm, because this is an EMG study. So if you lift the left arm, and it activates the muscle on the opposite side. So if I'm lifting left arm, it should activate the right. Every time low back pain comes, multifidus is involved. Yes, very high, strong association with it. Yeah. And I think in our primary education, we don't use this research at all. So that's why this lecture is very important, because, yeah. And we're going to talk about training multifidus. We're going to talk about how we can kick on multifidus, how we can selectively assess multifidus. But I'm just building the foundation of what research says and why multifidus is so important. Why we are here spending 1 hour of our life talking about multifidus, because it's a very important muscle. And that's why it has been studied so much. Okay. Okay. So let's talk a little bit about segmental innervation. And this is with reference to deep fibers of multifidus. Don't even think about superficial fibers of multifidus. We're just talking about deep fibers of multifidus, because deep fibers of multifidus has something called a segmental innervation, which means that if I have L5S1, multifidus between L5S1, it is supplied by L5. Between L4, L5, it is supplied by L4. L3, L4, it is supplied by L3. And we use this segmental innervation for our advantage when we are assessing patients, when we are treating patients, when we do EMG studies, when we are trying to find like spontaneous activity in deep fibers of multifidus. We use this segmental innervation for our advantage. Okay. So if you're treating a patient with L4, L5 facet arthropathy, I would definitely assess multifidus at that segment. And multifidus assessment is very easy. We're going to talk about it. Okay. And the amount of research available is just stupid. I keep saying that, but I mean, that's what it is. I mean, okay. So they have seen this morphological changes whenever you have back pain. The cross-sectional area of the muscle just shrinks or decreases, leading to intramuscular fatty infiltration. Okay. And that decreases the resting thickness. Even when the muscle is not contracting, the muscle volume has reduced. Okay. And when the muscle is contracting, they either by contralateral arm lift, because how they assess multifidus, if I have to check the right side multifidus, I would ask the patient to contract the arm on the opposite, lift the arm on the opposite side. And we did speak about this during our hands-on a lot. Okay. And so, or any trunk motion. And sometimes you don't even have to lift your arm. You just have to ask the patient to contract, kick on the transverse abdominis. You can ask them to hold the bladder. And sometimes if the muscle is working normally, it will help you kick on the muscle. Okay. Okay. Let's talk a little bit. Any questions till now? Okay. Because this is very theoretical, but any questions till now? Yeah. So make sure that you understand the orientation of the muscle, what it is doing, and with reference to deep fibers of multifidus, they are primary stabilizers. Some say they are also kind of rotators of the spine. Resting thickness is, so the studies were done on ultrasound imaging, where they were trying to assess the thickness of the muscle from side to side. Okay. Yes, the muscle thickness changes when patient contracts or patient lifts the arm, But resting thickness is patient is just in prone position, and you're doing a muscle ultrasound, and you're finding decrease in the width of the muscle. Okay. And this is a beautiful image. You can see how the muscle has been infiltrated with fat. We're going to talk about that. If there's a fatty infiltration, does it mean non-reversible changes? Actually, no. And that's what we're going to delve into that research, because yes, we are trying to find the problem first, and we're doing the research and finding the problem. And there have been researches done on treating this problem. Yes, I can share some link on Multifidus. I can share some articles, some good systemic reviews where they talk about, I'm going to share on the group, talk about research done to actually improve the patient condition. And these changes are reversible. That's what at least research says. So they have done a research where the patient had all these fatty infiltration, the severe changes, grade 2, as per Kajal classification. And the patient was undergone training for Multifidus and stability exercises, and they found that the width of the muscle improved. The fatty infiltration disappeared. Okay. Okay, let's build this up. Let's talk about the assessment. How would you assess? I've already given you this, but let's assess this. So what you're doing it, and I'm going to show it this on a skeleton because I don't have anybody in the clinic. So I'll show you it on the skeleton, how you do it and how you should assess. Okay. And let me just, okay. So the assessment part is important because it comes down to, I'm going to demonstrate on the skeleton on the side. So what you're doing is, if you're assessing on the left side, whenever we needle multifidus or try to assess multifidus, okay, we try to probably go like 1 to 2 finger breadths lateral to the spinous process. This is a spinous process, 1 to 2 finger breadths. If it's a smaller patient, 1 finger breadths. If it's a bigger patient, 2 finger breadths. Okay. And what you do is you ask the patient to lift the opposite arm. So if I'm on the left side, trying to find it here, okay, can you see my arm? I'm probably much closer so that you can see what I'm doing. Okay. Ask the patient to lift the contralateral arm. Okay. While patient's arm is flexed to 120 degrees, elbow flexed to 90, and only raise it by 90 centimeters, 5 centimeters. So the idea is just do a little bit of arm motion, because if you do too much, it's going to activate the superficial fibers as well. So what you're trying to do is just trying to keep your hand here and ask the patient to lift the contralateral arm. Okay. And you're feeling for the contraction. Intertestal reliability is not too bad. It's around 0.8. Okay. And this is a good picture. What you're doing is you're trying to just palpate in the interspinous space. Okay. And ask the patient to activate or lift the contralateral arm. Okay. You can look at the position of the arm in the picture. It's flexed to 120 and elbow is flexed to 90. They're lifting by only 5 centimeters or so. Okay. And when you do that, usually you will feel a good multifidus contraction. In patients where they have like no multifidus contraction or poor multifidus contraction, it will kick on longissimus, which is your part of erector spinae. And you will feel that your thumb is like, or your finger is thrusted towards the spine. So if you look at the picture 3 here, you're going to feel like the longissimus is kicking on and just pushing your thumb towards the spine, Okay. And that's why assessing this is so important. And you can go and assess each level, and you can combine this with your segmental mobility testing, which means that if your assessment says that patient has L4, L5 issue, or L3, L4 issue, or L5, S1 issue, you should find longissimus compensation at that specific segment. Okay. And this is very, very important because research says that we can train it segmentally as well. Okay. So one more time, in fact, I have to show you on the skeleton. All you're doing is find the interspinal space. You're palpating here. If you can see my finger, palpating here, you ask the patient to lift the arm, opposite arm, and you should, just by 5 centimeters, patient's arm is flexed to 120, elbow flexed to 90, and they're lifting only 5 centimeters. You should feel a strong activation here. If you don't feel activation and they're compensating with longissimus, your fingers are just basically moved towards the spine because of the contraction of the longissimus. Okay, you can see my fingers moving towards the spine, and that's the test. It's a very simple test. And once you do your segmental mobility testing, you know where what segment is a pain generator. You should definitely find multifidus atrophy at that specific segment. Okay. Okay, I'm going to move this away, and then I'm going to discuss more. Okay. Yeah, we're gonna talk about how we can train multifidus individually. We're gonna also talk about what exercises you can do to actually train, because what the research says, which are the preferable exercises, because there have been a lot of research done on choosing the right exercise if you're trying to activate the multifidus. Okay, so another test is standing test. What you're trying to do is, I'm going to actually demonstrate this on myself. Okay, so what you're trying to do is, you're trying to be close to the spinous process. Okay, you can see me, and you're standing in a staggered stance and shifting weight. Okay, and you can do it on your patient, and yeah, shifting weight, you should feel on the rear leg. So basically, if you're coming back, you should feel on the right side. Moving forward, you should feel it on the right side. As you move forward, you can feel it on the right side. Okay. The patient is kicking on multifidus. And you can start with L5S1, keep going up. Okay. Keep going up. Keep going up. Okay. And you can segmentally check. I like the test one, the previous test, because patient is relaxed, and when the patient is relaxed, you can have a couple of pillows. We're going to talk about what would be the findings of the stand test. So the stand test is the same thing. If patient is able to activate multifidus, you will feel the muscle belly underneath you. If patient is doing a longissimus compensation, you will feel that your finger is thrusted towards the spinous process. Okay, because patient is activating the bigger muscle, they're not able to activate. What we're trying to do here is, we are just activating really small, so the patient is not kicking on the bigger muscle groups. Going back to the recruitment pattern, small arm activation kicks on deep fibers of multifidus first, followed by the superficial fibers, followed by the rectus spinae. Okay, so if you do a little bit of motion, you kick on the multifidus. Okay, and this is a great test. Okay, if I shift the right foot, weight on right foot head, is it the right multifidus activation? No, I think it's the left. Because you'll always feel on the side. I will explain this like with more research backing. So if you're shifting weight away from the rear leg or towards the rear leg, you will feel the multifidus on the rear leg. Okay. So if my right leg is back and left leg is forward, and I'm moving the weight towards the left leg and bringing it back to the right leg, when I'm bringing it back to the right leg, I will feel it on the right side. Okay. So you're feeling in the phase where you're putting the weight on, not letting it go. So I'll actually explain this again because it will all make sense to you. Okay, with the various researchers. Okay, so this was the standing test. So when patient is putting weight on the right leg, the right multifidus will kick on. Okay, when it puts the weight on the left leg, okay, left multifidus will kick on, but you always look at the rear leg. The testing leg in this is the right leg. So when patient puts the weight on the right leg, you will feel the multifidus contraction, if that makes sense. Yeah. Okay. So we know what the problem is. We know that back pain is segmentally inhibiting, causing fatty infiltration in the deep fibers of multifidus at a very segmental level. What should we do about it? Yeah. Let's talk about the evidence. So there are various exercises we do and teach. We do quadruped exercises, just arm only. We do quadruped exercises with leg only. We do some Supermans, just arm only, leg only, arm and leg. Okay. I'm going to talk about what research says. Okay. And then quadruped prone progression, where we do both arm, both legs. What do you think is the best exercise for multifidus? Anybody? What does the research say? Any other exercises you can think of? Would you exercise multifidus in sitting with arm by raising the arm? Anybody? What is your go-to multifidus exercise? Let's have a little discussion on this before we jump on to research. Retro walk, okay. Mackenzie, okay. Anybody bridges and hams? Can we activate it by hamstring isometric on right? You can. Sitting on the edge of the bed and lifting alternate arm and leg, okay. Back isometric, will prefer the prone position. So let's actually have a discussion on what position do you think multifidus activates the best? It's the quadruped, it's the prone, or it's the sitting? Some of you are saying sitting. I'm going to just talk about from what research says, okay? Not what my opinion is and what I use. Because when you look at the literature and data, the data is like data trumps everything. I mean, so research says the worst position to exercise multifidus is sitting position. Okay, that's what research says. It says if you're trying to train multifidus, never use sitting position, because in sitting position, multifidus activation is the worst. Okay, so that debate has been settled. So don't use sitting if you're trying to activate multifidus. Okay. Okay. As far as prone and quadruped is concerned, you can use either or, but there is a catch. Okay. So this research, I'm going to show you the data published by DAFCU, and this data is very, very similar to the data published by a lot of people. So what they did was they compared resting prone position. So this is the first position, resting prone position, and patient is kicking on transverse abdominis. Okay. Resting prone position. And then they did Supermans with right upper extremity. And then they did Supermans with right lower extremity. Okay. And then they did rest at quadruped, where the patient is in quadruped position and kicking on transverse abdominis. And then they did bird dog, where they did right arm. Yeah. They did bird dog with right arm, upper extremity, right lower extremity. And then they did bird dog with right lower, left upper. So that this is like hardcore research, and this was done on normal subjects. I think that's probably not the best thing, but I mean, but the research said that if you're choosing the exercise as per this research article, which is where the results were very, very similar to other research articles, they found that the Superman of the upper extremity was the best position to activate multifidus. So if you're trying to activate multifidus on the left, Superman on the right side would activate it, and vice versa. What if patient is unable to attain prone and quadruped position? We'll talk about this. There are alternate methods too. Yeah, we're going to talk about this because we're going to talk about a lot of exercises and research and which are the preferable exercises. So they found that the Superman with just upper extremity motion activate the deep fibers of multifidus the best. So when you're choosing exercises, this is the best exercise as per research by DAFCO. And this is 2021, not 2023. Yeah. Yeah. And then they studied whether activating the upper extremity is better or activating the lower extremity is better. This was a correlational research. So they were trying to find whether when we activate the contralateral upper extremity, that is better, or whether contracting the ipsilateral lower extremity is better. And this was the data from same article, DAFCO. He talks about that multifidus thickness and CTR, which was contrast thickness ratio, are significantly greater with Superman upper extremity, upper limb, compared with all other exercises. But when they compared upper extremity with lower extremity, they found that it doesn't matter which exercise you do, whether you do quadruped or whether you prone, lower extremity activation on the ipsilateral side will be better than the upper extremity. Yeah. So this is I think this is very clear evidence of what exercises we should use. So we should use either ipsilateral lower extremity or contralateral upper extremity. Those are the two. And if you're using contralateral upper extremity, the position of choice is Superman's. Oh, position of choice is, sorry, quadruped. Okay. Another article by Okubo. Does by activating multifidus the job, or one gradually loads the muscle to get? I think multifidus is one of those muscles which, when we are selectively targeting deep fibers, we just need to work on activation rather than loading, because it has been seen that if you compress the spine too much, then the multifidus activation becomes poor. Okay. And that's why all the positions you're seeing are the positions where the spine is not compressed. So let me try to explain this point again. Okay, going back to the literature. So they compared Superman position, which is your prone position and lifting the arm. They found that prone position, when you're lifting the arm, that is called Superman, gives you the best activation when you lift the contralateral. So if I'm doing it on the right side, if I'm trying to activate the right multifidus, and if you look at it, this is also the test, right? This is also the test. So test is very similar to treatment. Okay. So if I'm trying to train the multifidus on the right side, Superman with left arm lifted is the best position if I'm trying to train that muscle. When they compared the research from upper extremity and lower extremity, they found that when you're training the muscle and you're trying to improve the thickness of the muscle, you should encourage more lower extremity exercises compared to the upper extremity lifting task. And it doesn't matter whether it's quadruped or Superman position. Okay. And that's what research says. Coming back to the point where you said patient is not able to activate quadruped or prone position. What are the other positions we can use? Let's look at other exercises which were studied. So they studied these positions where this is plank with contralateral arm and leg. Okay. This is bird dog with arm and leg quadruped position. Okay. And then they did bridge with single leg lift, same side, opposite side. And they did plank with leg lift and curls. Yes. What do you think? What do you think is the most preferable position to activate multifidus as far as research is concerned? And actually, the point you're saying, plank does increase pressure on the lower back. Absolutely. And any exercise that compresses the spine, any exercise that compresses the spine shuts down the multifidus. So whenever you're training multifidus, don't choose exercises that causes pressure in the lower back. Yeah. Anybody who can tell me which? So let's look at what research says, what data says, and this is purely from the research they studied the maximum voluntary contraction, and they studied the EMG amplitudes of deep fibers of multifidus, and they found that when you do a bridge with right leg, and we're talking about right multifidus. So if I'm trying to train the right multifidus, say right multifidus L5, S1 or L4, L5, and I do bridge with right leg, that tends to activate the right multifidus the most, followed by back bridge, followed by a bridge with opposite side, followed by ipsilateral leg and contralateral arm in quadruped position. Yeah. Make sense? I know this is a lot of information, but when you're selecting exercises, the 4 exercises I would select, just purely looking at the literature, is Superman upper extremity, contralateral side, how to train multifidus with canal stenosis. You can use quadruped hand, ipsilateral arm, ipsilateral leg, contralateral arm, right? Quadruped doesn't causes, it causes, you're doing the exercise in relative flexion of the spine. Okay. Will multiple in canal stenosis? Absolutely. It doesn't matter whether it's an intervertebral problem or a facet problem. You will find multifidus atrophy, very, very common. We have seen that even if patient has like central sensitization, has low back pain because of central sensitization, multifidus tends to shut down. Right leg bridge means that, this is the right leg bridge, let me show you. Right leg bridge means that right leg is in the air. Yeah. Right leg bridge means that right leg is in the air. So if you look at position 7 on the picture, that outperformed everybody else of all the positions to activate the multifidus. Followed by position 6, followed by position 8, followed by position 5. So if I have to say from this picture, so idea of discussing all this is that we think about multifidus, we assess multifidus, and we treat multifidus, especially if you're treating chronic low back pain, because the amount of evidence is just overwhelming. Okay. Now we know how to assess multifidus and how to assess for longissimus substitution. Right leg up should mean left leg multifidus activation. No, right leg up means The figure 7 says that the patient is exercising on the left leg and is using the right leg. Right leg is in the air. That means right multifidus activation. Yeah. Yes, would activate hamstrings, but they were just studying multifidus. We are not trying to look for hamstring substitution or glute substitution. We are looking for multifidus activation here. Okay. So if I have to tell you the 6 exercises, 5 or 6 exercises I would use for multifidus. And depending on the patient population, I would definitely use the bridge with affected leg in the air. Yeah. This is a second is Superman's with contralateral upper extremity. Yeah. I'll probably do the bridge as well. Bridging. And then I would use quadruped. That's what literature says. Quadruped ipsilateral leg. If your patient can definitely not do spine extensions, quadrilateral ipsilateral leg and contralateral arm. Yeah. So these are the exercises of choice. What about in case of ankylosing spondylitis, a different condition? Usually you will not find segmental inhibition. You'll probably find inhibition all around. I mean, I think it's not very relevant to this lecture. But yeah, I mean, we're trying to find like a strong correlation with the people who have attended our lumbar spine lecture, which some of you have, will be able to correlate because we try to assess problems at a segmental level, and we teach in a way that our clinicians can assess at a segmental level, and not only assess at a segmental level, they can assess multifidus at a segmental level. If you're not able to achieve any position, then will diaphragmatic breathing having effect on transverse abdominis has a strong correlation with MF activation. So when you're doing diaphragmatic breathing, you're definitely activating your TRA. Yeah. If you have geriatric patients, I mean, you'll have to find some other exercise, maybe like standing shifts. Those are not the most preferable exercises, but yes, standing shifts can actually help you activate. So this could also be a test. The test we did could also be treatment. Yeah. Any more questions, guys? I think this is the lecture. I mean, this is it. I mean, any questions? And it was a short lecture, but I mean, this is all the information I had to share. Okay. Post-spine surgery, absolutely enough evidence out there that laminectomies tend to shut down multifidus at the same level on the same side. Yeah. I will share some of the articles. Yes. Chronic back pain, anything that affects the arthrokinematics of the facet at that specific segment shuts down the deep fibers of multifidus. Okay. We did discuss the theories. So yeah, there's enough evidence out there. Okay. We'll put this lecture on YouTube so you guys can go and revisit it if you feel like. But I mean, contraindications, I don't think, do you have to isometrically hold the muscle contraction for a particular time? Yes, you can. If you're training the muscle isometrically, you can do a TRA multifidus co-contraction. I don't think there's any contraindication for working on multifidus. Okay. This is a very specific information, specific lecture, because we're trying to look at the muscle recruitment of multifidus in stroke or any other neurological disorder. Yes, I mean, the deep muscle firing can be affected in other conditions too, but this lecture is relevant from the standpoint that whenever we treat back pain patients, which as a therapist, most of us do, we definitely should assess lumbar spine at a segmental level and then assess multifidus at a segmental level. Okay. And the assessment is very simple. And the research and evidence says that if you train and do the stabilization exercises over the period of time, you can change the atrophy. These changes are reversible. I can share the article with you. Okay. Where they found like grade 2 problem, grade 2 atrophy of multifidus at a segmental level. And then the patient went through the multifidus stabilization program, and they could visibly see changes within 8 weeks where they saw like increase in girth of the muscle on ultrasound. And that is why we're discussing this, because amount of research is just too much. Okay. Can we check the MMT of multifidus by the same time? I don't think you can do MMT, but you can definitely selectively test multifidus. Can deep needling in multifidus motor acupuncture can address muscle? I don't know the research on it. I mean, we do dry needle multifidus all the time. Does it improve the activation of multifidus? Who knows? But definitely from like exercise standpoint, we should always work on this. Yes, we will share the link. Yeah, we'll share the link. Okay. Can multifidus be the only reason for? I don't think back pain is unifactorial. I think the training, the time frame they used was 8 weeks. Okay, so they put these patients who had grade 2 changes. They put those patients on a 8-week stability program, and they found like improvement in girth. And that's why this, whenever we discuss stuff, I think it has to clinically make sense. And role of multifidus in athletes, it's the same thing. If you have back pain, you have facet issue, you're going to find segmental inhibition of the multifidus. It doesn't matter what patient population you're treating. If you're treating low back pain, you're treating facet involvement, you're treating intervertebral space is getting narrowed, you have spinal canal stenosis, you're going to find multifidus changes in those patient population. Okay. I think earlier they used to think that these changes are seen in chronic patients, chronic low back pain. I can share that article, and I can tell you what the repetition and frequency. I don't remember on the top of my head, but I can share that article with you. SIJ and muscle in multifidus involvement. I couldn't find any article on SIJ and multifidus involvement, but whenever you have SIJ issues, you can also have L5S1 issues, and that definitely shuts down the multifidus. Changes in the multifidus are due to same principle. Your body's protective mechanism. That's what dorsal ramus syndrome says, that it is the irritation of the nerve that supplies the joint, supplies the muscle. Or if you have to look from the reflex inhibition theory, it says that whenever you have facet involvement, when you have like degenerative changes, it stretches the capsule, activates those inhibitory interneurons, thus shutting down the muscle. This is a form of arthrogenic inhibition. We just only think about arthrogenic inhibition for quadriceps and ACL injury. We never think about arthrogenic. This is a kind of arthrogenic inhibition of the back muscle of the multifidus. Yeah. And yeah, I think in some literature they do use the word arthrogenic inhibition, but technically it is arthrogenic inhibition. You have a joint involvement and you have a muscle involvement. But the difference is from knee or from hip, the difference here is that the involvement is so much segmental on the same side at the same level, which is not found in any other muscle group. Okay. And if they test the opposite side, when they tested the opposite side was fine. Okay. Any more questions? So yes, that's the thing. Acute low back pain, multifidus starts to get involved and it becomes chronic. The involvement is definitely more with fatty infiltration. But with acute low back pain, multifidus starts to get involved. The activation pattern reduces. They've done EMG studies on it where they found that even in first 30 days, they start to see changes in multifidus. Okay. Does walking helps? Yes, but I think the idea is that we use the research. We have clear evidence and research and exercises of what exercises to do. Okay. And whenever we're treating patients, I think it doesn't hurt to be more accurate when you have the scientific evidence available. Okay. So some of the exercises we discussed, the idea is definitely assess multifidus. People who attended the hands-on, we did like this small activity where everybody felt how deep fibers of multifidus feel like. Okay. And that's why hands-on is important, because that's why we love teaching this. Because I mean, yeah, can exercises like deadlifts help to strengthen multifidus? Yes and no. When you're doing like a very heavy activity, deadlifts will cause some spinal compression, so hard to say. But whenever you're doing any heavy activity, then you're using all the muscle groups. It's hard to say whether you're using multifidus or not. So do exercises that selectively targets multifidus. And that's why research is important, because cat and can helps in activation. I didn't find any research on it, to be honest with you. It can, it may, but this was not, I mean, you look at the literature and you try to find answers in the research and literature, right? So cat and camel may help, but it's hard to say. Because if you have better exercises which have been proven in research, why not use them, right? Unless you have situations where you can't use them. Yeah. Any other questions, guys? Sorry, this was a quick lecture, but I mean, I think the information is relevant, and I'll share a few articles about what stability program they used. All spinal bond indication multifidus training. Definitely assess it. It doesn't hurt to assess it. If you're finding no problems with multifidus, that's fine, right? You do an exam on first day, you assess it. If you find problems with multifidus, which you will, because the amount of research, why would they do so much research on multifidus if it was not important, right? So any more questions, guys? So just wrapping up this lecture, 4 exercises to do. Superman's with contralateral upper extremity. Okay. Bridging with ipsilateral lower extremity. How MF can help for facet impingement. So there are situations where you have a situation with facet impingement, and we use muscle energy techniques, and we activate some fibers of multifidus to address facet impingement. Do we selectively activate deep fibers of multifidus when we're doing that technique? I'm not too sure. Okay. With facet, if you talk about facet impingement as a diagnosis, the research is very clear. Facet impingement can cause multifidus to shut down. But the good thing is that especially with facet impingement, especially in lumbar spine, most of the patients are acute. Okay. So if you have seen a patient with facet impingement, they usually come to you right away because of the severity of symptoms. Yes, I can repeat the 4 exercises. Okay. So exercise number 1 is Superman with contralateral upper extremity, bridging with ipsilateral. When I talk about ipsilateral, it means that leg is in air. Ipsilateral upper extremity. Okay. Third is you can use back bridges as well. Fourth is quadruped contralateral arm, ipsilateral leg. Yeah. Yeah. So you can use other positions given in the research, and there is a reason why they used all these positions, because they were expecting them to be superior than other exercises. So you can use all these positions, but the positions of choice are the 4. It is necessary to follow the sequence exercises. I don't think it's necessary to follow the sequence, but it is important to understand what exercises help. and what research says. Because whenever we have like good evidence, we should use it. That's why we teach evidence-based stuff, because we have good evidence and we can use it to help our patients, right? Yeah. Any more questions, guys? I know this was a quick lecture, but I mean, this is important information as far as low back pain is concerned. Yeah. And I'll share the article. I'll share the article on the group, few Multifidus articles. I mean, okay, few systemic reviews, and then there's an article which they used to actually study. They used to actually train Multifidus. Okay. And they could find changes in as early as 8 weeks. Physical changes on ultrasound pre and post. Okay. Bridging with contralateral upper extremity, ipsilateral lower extremity. Yeah. At least that's what research says. Okay. I think there is a quiz afterwards. I think quiz link. I mean, this is make sure that if you're paying attention, you should have no problem scoring well on the quiz. And I think it's a good test for you. Hope you learned enough, I mean, from this lecture. And next time you see your low back patient, you're assessing multifidus. Okay. Yeah. Any more questions, guys? I'm going to stick around for 5 more minutes. If you have any more questions, please.